anatomy is more internal than external. So our gonads are actually our ovaries, homologous with testicles. It's just that during development for a baby, the testicles actually traveled down to the scrotum. Females stayed in place, and that's where eggs, ova, are gonna be developed. So, hormone-wise, it's not that women don't have testosterone, because we do, and men have estrogen. But our major players in the female reproductive system is estrogen and progesterone. Every month plays a role. Our reproductive organs are actually inside the pelvis. So, hypoperitoneal. It includes the ovaries, the uterine tubes, also known as the oviducts, also known as the fallopian tubes. Are y'all tired of saying that? Because I am. But I just want to make sure y'all understand, when you see one of these words on your test or on your lab test, I'm not sure how Dr. Johnson's going to put it on there. They got 3 names. So, okay. And then the uterus carrying the baby, and the vagina. All internal. But externally, we do have some things. Okay, I made a boo-boo and I went forward, then I went backwards, so I got to do it again. Dang it. Of course, you wouldn't know that because you're just listening to this now. Okay, bottom right-hand side, external genitalia. Notice that external genitalia is called vulva. So what you see is the vulva. So starting with the mons pubis, this is a fat pad that is protecting the female at the pubic bone. Men don't really have this so much, so their vas deferens / ductus deferens actually travels up over this bone as the sperm leaves the testicle and travels up the vas deferens during ejaculation. That little passageway, that tube, is actually sitting right on top of that bone. So another way that a man can actually hurt himself is just bumping up against the pubic bone. Okay, so mons pubis. Inside that mons pubis is the homologous structure to the penis called the clitoris. And it also has a tissue just like corpus cavernosum that does engorge with blood during sexual excitement. It has an end that's exterior, and it's a homologous structure to the glans penis. So this is the stimulatory organ. The next thing it's pointing at, well, notice where on this slide, notice where everything is located. So the bladder is actually kind of deep to the uterus. And so when there's a baby inside that uterus, the baby actually really does use the bladder as a trampoline as it wiggles around. You feel the occasional push. So mom really does need to go urinate more often, because there's constantly this push that says you need to go, you need to go, you need to go. They can hold less. The bigger that baby, the less room there is for urine to be held. But then there's also that stimulation of the baby kicking the bladder. And then just posterior to the uterus is the rectum. So you can see that any inflammation of the uterus can cause like a generalized pelvic discomfort. You could say it's a referred pain, but it's not even like a referred pain, because it's physically going to be sitting right up next to those other organs. So the inflammation has potential to touch either of these organs, especially endometriosis, which we'll get to in a minute. Okay, so then it's pointing to the external urethral orifice, so you can see, you should definitely be able to point those out on a lab test, the difference between the two locations. Next, greater vestibular gland. So the greater vestibular gland is a homologous structure from embryologic development for the man's bulbourethral glands, in your lab book called the Cowper's gland. This is going to be during sexual excitement. This is going to increase its secretion for moisture in the vaginal area. So two protectors of the vagina, keeping dust, dirt, bacteria out of the vaginal canal, is the lips. So labia means lip. Labia majora is the more external part. It's the part that actually has hair on it. And then deep to that is labia minora, and it does not have any hair on that. Other things to note on this, the uterus is pointing out the perimetrium is kind of the outside part of the uterus. The myometrium should be marked, I hope, on here. No, but it's the muscle part of the uterus, and the endometrium is the inside layer. We definitely get into a little bit more detail on that in a minute. You can see the oviduct / uterine tube / fallopian tube, ending with those little fingers called fimbria that are have the cilia on the inside of them, always waving that ovum that has ovulated to bring it back towards the uterine tube. At the cervix on this picture, on either side is something called a fornix. So that cervix actually kind of dips deep into the vagina, and it has these little hidden areas. Well, a couple of things. This allows the cervix to dilate, and that muscle is going to flatten out when it's time to have a baby. But also, this is a great place for sperm to hang out for about a week. Now, so what does that mean? That means that sex 1 week before ovulation has potential still to make you pregnant, because sperm can actually live in the vagina for up to a week. So I always err on the side of caution in life, so I would say be careful if you don't want to have a baby. Here we go. So here's the layers. The muscle layer is myometrium. That makes sense, I hope. Perimetrium's the outside. The endometrium is on the inside. One thing we're going to learn about the endometrium is it's ever changing. So you have a layer called the functional layer that is going to slough once a month if you're not pregnant. There is a steadfast layer, a base layer that doesn't change, obviously, that's going to be making that functional layer, the deeper layer that is going to be where the baby can set up house. Looking again, so we have the body of the uterus, we have that uterine tube with those little fimbria on the end. The fimbria have the cilia that are going to wave the ovum towards it. If the cilia aren't working on the fimbria, or the fimbria are deformed, you can't wave that ovum into the tube. So if you don't have that functioning, that ovum is just going to go free float into the abdomen, and that cell can't live on its own very long, so it just dies. Now, weird things can happen where this is rare. But if sperm actually make it up into the tube and goes out of the uterine tube into the abdomen and finds that ovum, that would be an ectopic pregnancy that's in the abdomen. Another possibility would be the egg gets fertilized in the uterine tube, or somehow that fertilized egg, instead of traveling down into the uterus, falls out into the abdomen. Ectopic pregnancy doesn't always mean just in the abdomen, though. It can be a baby that's actually growing in the tube, but that's not compatible with life. So as the baby expands, if it sets up house in the uterine tube and starts to grow, the uterine tube is going to rupture. Then there won't be support for the baby. The baby will die, and potentially mom can die because she could bleed to death. Notice all these ligaments that are suspending the ovary and the uterus and keeping it upright so it's not just a big old wad on the pelvic floor. And I'm not really going to get into all these different ligaments and the isthmus. They are important for surgery. So perhaps if you decide that you're going to be a surgical nurse or a nurse for a gynecologist, you're probably going to have to learn these terms in nursing school. Anyway, moving on. So, just like a lot of the other organs that you've met, the ovary has a cortex and it has a medulla. The medulla is where we got lots of blood vessels and nerves. It's about twice the size of an almond. And when we're born, when baby females are born, many follicles. However, the follicles that you're born with are actually way less than what formed embryologically. So we're going to end up with about 400,000 of a few million that got made originally. Once a month, once we hit puberty, the ovary is going to go through ovulation. So I keep saying that this oocyte's going to go into the belly. Well, and then we're going to have it called back into that. So what that means is that uterine tube does not directly link up to the ovary. Isn't that crazy? It's all suspended by ligaments. Oh, look, and there we go. Uterine tube, also called fallopian tube, also called oviduct. That's where the ovum is supposed to go, and that is where fertilization is supposed to happen in there. So the fimbria are the guy that are supposed to be waving all the time and bring that ovum back into the oviduct. The rest of the tube system is the uterus and the vagina. Mentioned that already. Forgot that I had a slide on that. So it must be important because now it's mentioned twice, right? I thought of it and here's a slide on it. So ectopic pregnancy is a big deal, and someday I would like to think that if a woman finds out that she has a tubal pregnancy, which is an ectopic pregnancy, I would like to think that they could figure out a way to get that baby into the uterus so it could finish developing. But as it is right now, the blood supply is all established. So you can't just pull that embryo away from that blood supply and make it reseed. All of those villi were formed when the chorion was making its little, when the trophoblasts were actually embedding in there. So pretty early on, first week. So you find out later that it's an ectopic pregnancy and you can't do anything about it. You can't move that baby without killing the baby. So I'm hoping somebody's working on that. Again, rare, more rare to have an ectopic pregnancy in the abdomen than in the tube, but still sad nonetheless. Okay, so the uterus has a body and a cervix. The cervix is the neck. That's how it gets its name. Cerv is neck. And the cervix actually has glands that create mucus to block sperm. So if it is not time to get pregnant, the uterine tube, vagina, has this plug of mucus that's keeping the sperm out. Except during ovulation, when it's time to get pregnant. Already said all this. Myometrium is the part that's actually going to go through contraction and relaxation. That's what causes the pain. Obviously, muscle contractions, myometrium. The endometrium has the two layers that I mentioned already. The functional layer is the part that's going to continuously change. It changes based on hormones and whether or not you're pregnant. So even if you're not pregnant, every female has constant fluctuating cycle during the month, And this determines the buildup of that functional layer or the shedding of that functional layer. And then we have a base layer that never changes. His job is to create the functional layer, which is the layer that's responsive to hormones. So almost like a stem cell layer, like we did in skin and like we did in spermatogenesis and oogenesis, which I talked about in lab. You have that base cell that's going to go through mitosis. One cell is going to stay a stem cell, and the other cell is going to become a primary spermatocyte. And skin, you had the basal cell layer, one division, mitosis, one's going to stay a basal cell, and the other one's going to become a keratinocyte. This is the same idea. You've got the basement layer that's constantly making the functional layer. The functional layer is the part that changes based on hormones, not the base layer. The base layer is just like, I need to replace that. You did it again every month. Why you do this? Okay. Okay, cervical cancer is a declining problem, but still way out there because it's not just virus related. It can happen for other things. However, the reason that it is declining is because we have the vaccine now that's for boys and girls. Human papillomavirus is what HPV stands for. I should probably write that out. Human papillomavirus. And it's sexually transmitted. So that's why boys have to get this, do they get papillomas on their cervix? No, because they don't have a cervix, but they can carry the virus. So, other things can happen too. You can get cancers for other reasons besides viruses. But half the women that get cervical cancer will die from it. When you get a pap smear, I'm not even going to try and say the name, a pap smear. The purpose for the pap smear is to check for changes in the cervical cells to try and catch this before it becomes a problem. Prolapse of the uterus is not that common. It does seem to have a little bit of hormone cause in cattle, but we aren't cattle. In humans, it's from tearing of muscles during childbirth, overstretching of the ligaments, all those ligaments, the suspensory ligaments, the round ligaments, another biggie, did I say broad ligament? I don't know if I said the broad ligament. Broad ligament's actually broken down into a whole bunch of different sections. So with childbirth, some of these ligaments tear, muscles get loosey-goosey at the pelvic floor, and then what ends up happening is the uterus kind of falls out of the vagina. Needless to say, that's not good. It can be fixed, though. So this is showing both a part of the muscle layer and then all of the endometrium. So you have the basement layer, again, that is not changing with hormones. It's just constantly replacing the functional layer. The functional layer is the layer that responds to hormones. So basal layer, functional layer. Okay, the vagina is a muscular tube. It has three purposes. It's where babies pass through, menstruation happens, and copulation happens. The urethra is anterior to the vagina. And we've mentioned this already, that the vagina is acidic. Now, in adolescence, it's alkaline. They shouldn't be sexually active, so it shouldn't matter. The mucosa near the orifice that is intact before sexual intercourse is called the hymen. It's another protective thing for the vagina. And then there's that fornix that I pointed out, that dip that is around the cervix, and it's a place where sperm can get caught and hang out until an opportune time. Went through this on that picture, so I'm going to keep going. Went through this on the picture, so I'm going to keep going. So here's a different view. You can actually see the urethral orifice compared to the vagina. You can see that the actual exterior part of the clitoris right there, so that's the sexual stimulatory organ that is homologous with the penis. That little tip right there is homologous with the tip of the penis. And then the lips. You have the haired lips, and then deeper to that you have the unhaired lips. So haired lips, labia majora, unhaired lips, labia minora, and they're all protecting the vagina. Mammaries. So, you know, the function of mammaries is only for females. Men have mammary glands, and men can get breast cancer, but rare. Because it's rare, it makes it more dangerous in men because men don't do self-examinations. So, and of course, the function of it is to give milk to a newborn baby. The pigmented part around the nipple is called the areola, and we actually do have ligaments that are attaching the breast to underlying muscle for support. Suspensory ligaments. So the second most common cause of cancer death in women is breast cancer. 13% is pretty high. That's more than 1 out of 10 women that can develop that. Sometimes we know that there's a hereditary factor, and you can get tested for the different BRCAs, BRCA1, BRCA2, I believe is what they're called. There are different kinds of breast cancer, which if you decide to go to nursing school, you'll probably learn about the different kinds of them. We're not getting into that today. But different causes, if for some reason people that start menstruation early, like 9 and 10 years old, they're more likely to get it, or really late start to the first menstrual cycle, so 18, 19 years old, which is uncommon, but it happens. Not having any pregnancies, or having your first pregnancy late in life. Not breastfeeding, and then of course family history of breast cancer. Early detection, self-examination, getting mammograms routinely. The American Cancer Society recommends it once a year. I remember probably about 5-7 years ago, they started with the, maybe it was longer than that. Maybe we can get away with doing it every 3 years. And there was a real pushback from doctors because they felt like this was a insurance plot to save money. And as far as I know, the doctors won on that because my insurance still pays for this once a year. Now we have all kinds of cool mammograms. You can get 3D mammograms, and if there's anything suspicious, then they'll move on to ultrasound. So anyway, lots of ways to try and prevent it and catch it early. So this is showing a normal breast and then an area with a lot of density. Now that being said, sometimes like even caffeine can cause dense breasts. So a lot of times they'll just do follow-ups, or maybe they would just go ahead and biopsy this one because it's kind of big. But anyway, just depends on comparisons and what can you feel. Okay, so fun. Oogenesis. So that's supposed to be production of a female gamete. Wonder what happened to the TE. Not the female game. Okay, oogenesis is embryologic. Men go through spermatogenesis constantly. Oogenesis in females is embryologic. So we're going to start with that excuse me, oogonium, and it's going to go through mitosis. One of them is going to become another oogonium. The other one's going to become a primary oocyte. That is going to be what freezes at prophase 1 at birth. So any of those primary oocytes that got to stay, that's what a fetus, that's what a baby is going to be born with, is a bunch of primary oocytes. When we ovulate, that ovulation is a secondary oocyte, and that guy is going to freeze at metaphase 2. I'm saying all this because I've already done it in lab, and repetition is key to learning, and this seems to be the toughest part of physiology and reproduction. Then, if there's fertilization, that secondary oocyte is going to finish off, moving on from metaphase 2, finishing off meiosis 2. It's going to be called an ovum, and it's going to lose part of its shell and become something called a pronucleus. So is the males, and the two DNAs are going to come together. The pronuclei with the DNA come together. We can lose all the cytoplasm now. We've accomplished our job. So I just said all that, but when we're born, primary oocytes are going to be in the follicles of the ovary. They're going to be frozen at prophase 1. And remember, prophase 1 is all about crossing over, genetic diversity. At puberty, then we're going to recruit these primary guys, several of them once a month. And one of those guys is going to become the secondary oocyte that comes out with ovulation. Meiosis 2 does not complete. Meiosis 2 does not complete unless there is fertilization. Okay, then we have different stages of follicles. So we have these primordial follicles that have not been recruited. So they're hanging out, and they're dotted throughout the ovary. Okay, so about 400,000 of these guys. Now, once a month, we're going to recruit some. And what's going to happen is what was a very thin layer around each of the potential ova is now going to be more of a cuboidal layer. It's going to get thick, and it's called the zona pellucida. Then, as we start to mature and we're trying to decide who's going to be the best one, some of them are going to develop at faster rates or slower rates a stratified cuboidal layer. And that's going to be secondary follicles, but they still have a primary oocyte. Only one of these guys is going to actually become, unless you end up having twins, usually only one of these guys is going to ovulate. Only one of these guys is going to get big and fat. Their zona pellucida has expanded really big. It's got a giant fluid-filled cavity called an antrum. And it's going to be the Graafian follicle that's going to release the secondary oocyte. The other guys that temporarily became secondary follicles, they're all going to poop out and wither away. That's called atresia. So that one guy that's made it to, that has made it to Graafian follicle, that one guy is going to go ahead and start meiosis again, becoming the secondary oocyte, but he's going to freeze up at metaphase 2. So all that oogenesis begins during the fetal period, but nothing is complete, of course, until that egg gets lost. And you know what? Not all 400,000 of them get to get used. Trying to think if I said this already. Oh, one thing I forgot to talk about. The lab book and the lecture book don't show really primordial follicles drawn in the ovary. Maybe it should just say the lab book or the lecture book. I don't remember. But anyway, that's what the recruitment is about. I have these primordial follicles. I'm going to recruit however many. I keep saying 10, but it's probably more like 100. Okay, let's see what you can do. And then they're going to, as they change from just that thin layer around the primary oocyte, they're going to become cuboidal, and that's going to be a primary follicle. And then that single layer of cuboidal is going to become stratified. So we're making it to a secondary, but most of them aren't going to get past that to Graphian. Only the guy that's going to ovulate is going to become a secondary oocyte. So what activates all that? What gets all of that going? Follicle stimulating hormone. Does that make sense? Okay, I need 100 of you guys. Let's go, let's go, let's go. That's FSH's job. Okay. Now, what encourages ovulation is luteinizing hormone. We're going to have, this is one of those weird places that we really don't mention very often about positive feedback. You know, we talked about having a baby and blood clotting and milk letdown. But actually, we're going to have a little bit of positive feedback here. But that's not on this next slide. We'll talk about that in just a second. I want to talk about a term called Mittelschmerz. So some females will say, oh, I hurt, I'm ovulating. And you might think they're crazy. But in fact, it's a twinge of pain that you can actually feel that the egg is popping off if you're in tune with your body and, you know, maybe you're not busy, whatever, doing something else. I suppose if you're sitting still and you aren't focused on something else, you can feel it. Now, some people actually do have painful ovulation and may have more to do with if it's more of a cystic, maybe an oversized follicle. I'm not sure. But so in fact, you don't have to call somebody crazy if they say that they have a Mittelschmerz going on right now. Okay, so most of the time you just ovulate one ovum, but occasionally people will release two. And so you've got two separate eggs. Remember, they've been through genetic diversity way back when in the fetus. So you have you had crossing over at prophase 1. So with that, and then you have two sperm coming to those two secondary oocytes, and they have genetic diversity. So then you're going to have fraternal twins. They don't look anything alike. Identical twins, what happens is after fertilization, during the cleavage phase, something ends up happening and you separate the blastomeres. So we ended up with two little balls of blastomeres, and then they restart their cleavage phase. And that's identical twins because they're the same DNA. Okay, so all that we've been talking about is called the follicular phase of the ovarian cycle. So just in summary, we have FSH is going to show up thanks to the brain, and we're going to recruit several follicles to start to develop. About midway, what's going to happen is the follicle stimulating hormone is going to drop. So only that one big guy gets to keep going. There's going to be a surge of estrogen in that guy, and he is going to keep going. That primary oocyte is going to finish meiosis 1 and get frozen in metaphase 2. And unless that secondary oocyte that pops out of that follicle gets fertilized, then that's it. He's not going to finish metaphase 2. Okay, usually the first 14 days are the follicular phase of the ovarian cycle. This can vary a little bit between women. Picture for those of y'all that like pictures. I love pictures. More pictures. Let's do this corpus luteum real quick. There's probably a slide here in just a second. But one thing that I haven't mentioned in this PowerPoint yet, mentioned it in lab, is, okay, so the ovum left. The ovum has popped out of the follicle. What happens to the follicle? The follicle gets changed names to a corpus luteum, and he's going to release progesterone. Progesterone would maintain a pregnancy for 3 months until the placenta takes over. But what if you don't get pregnant? If it don't get pregnant, that corpus luteum is going to figure it out pretty quick, within 5 to 7 days, and start to become something called a corpus albicans, and it's all just going to scar up and be done at that spot. On the right-hand side, when we talk about meiosis completing, we have one guy that needs as much cytoplasm as possible. So that one guy is going to be bigger on meiosis. The other guy, the separated guy, remember we divided it into a group of N. So we took those 23 chromosomes on the left, went to one side, 23 chromosomes on the right to another side, finished telophase. Now we've got 2 daughter cells, but one of them stole all the cytoplasm. So the other one doesn't have enough cytoplasm to keep going. That's going to be called a polar body. He also can go through meiosis too. Again, maybe, maybe not. Who cares? It doesn't matter because he's pointless. So he might not because he just dies right away. It doesn't matter. I don't know why they mention it. The point is moot, except to show you that we have potential for 4 separate cells, but only one of them is worth anything. So here we are. So you've ovulated. We've got the secondary oocyte, finishes out meiosis 1 and goes into meiosis 2, but freezes at metaphase 2. Unless a sperm meets him. And then what's going to end up happening is the genetic material is going to form something called a pronucleus, and the 2 pieces of genetic material, the 2 pronuclei, can come together. Picture. This picture is also in Blackboard. Okay, so we've done with the follicular phase. Let's talk about the luteal phase. The luteal phase is definitive. So I said the follicular phase varies amongst women. The luteal phase is always 14 days from ovulation to the end of the cycle. Okay. So this is, obviously, if we're calling it the corpus luteum, this has to do about that guy, that luteal phase. What is he doing now? What's his job now? After we have popped out a secondary oocyte, what's going to happen to that follicle? And hopefully you figured out, why does that matter? Well, because he's going to maintain a pregnancy if you're pregnant for a while, if he works. He, she. So in lab, we have this very large graphene follicle that, notice, it's filling up with all kinds of cells around the edge, and there is no external little point that's separated out. This area is thickening and changing its purpose. Okay, when immediately after an egg leaves the follicle, there's going to be a little bit of blood, because the ovary does, in the medullary area, it does have capillaries. So when that pops out, that antrum is going to fill up with blood. And again, this is visible with the naked eye. So I told y'all in class that the corpus luteum is visible with the naked eye. It looks like a little whitish yellow pimple. Same thing with the corpus hemorrhagicum. I tell you, I see these in cats all the time, because cats are continuous cyclers. They continue cycling until they get pregnant or spayed, which is the route that I would recommend. But anyway, when I'm spaying a girl kitty, I usually am either going to find a Graafian follicle or corpus hemorrhagicum or corpus luteum. So their ovaries are very evident because they are continuous cyclers. So I should get some pictures in here. Okay, so those cells that were around the edge of this follicle are going to change and start to come up with their own function to release progesterone. They do release some estrogen too. But if no pregnancy occurs, he's going to end up finishing up his release of progesterone, kind of start to shrivel up, become corpus albicans, and then scar in. So this is actually going to be pretty quick. We've already said all these things, well, most of these things. So oogenesis begins in fetal life. Spermatogenesis for men begins at puberty. They're not producing sperm until they start to go through puberty, but they'll go through it for the rest of their lives. Women, oogenesis stops at menopause. So we're going to quit all that ovulation because it's not time to have babies anymore. Error rates. Spermatogenesis has a pretty low error rate, and women have a pretty high error rate, up to 20%. Hormones. Okay, so gonadotropin releasing hormone, you remember him from the hypothalamus, is the guy that's going to stimulate the anterior pituitary to release follicle stimulating hormone and luteinizing hormone. FSH and LH are going to stimulate that follicle to grow, and that follicle is going to secrete estrogen. And then you're going to have negative feedback. The more estrogen you have, you're going to start decreasing FSH and LH until they have that one guy that says, I am strong enough to beat this. I have enough estrogen to keep going. I am going to be the Graafian follicle maker that's going to spit out a secondary oocyte, and the other guys are going to atresia. Can't remember if I said that on this. Atresia is the name of the withering away of a cell. So atresia is what the other 99 follicles that did not have the strength to go on, that couldn't stand this dip in follicle stimulating hormone because they weren't producing enough estrogen to maintain themselves. Then here's that positive feedback that I was talking about. You had that dip, and now that follicle is going to start to spit out even more estrogen. He's going to start putting out even more estrogen all on his own, and he is going to stimulate a release of gonadotropin releasing hormone, positive feedback, and we're going to have a massive high peak, and we're going to cause a luteinizing hormone surge now. So because of this very temporary elevation, we're going to have luteinizing hormone. So what's important on this page for your lecture test? Your lecture test is you had one guy that was super amazing that fought the FSH peak. He kept releasing some estrogen, and that made the brain say, oh, okay, here's some follicle stimulating hormone. Here's some luteinizing hormone while we're at it. And boom, It's time to luteinize. How do you luteinize? Ovulate. It's time to luteinize. So as soon as you get that release of luteinizing hormone, that's telling the body it's time to let go of that primary ovocyte. Let's make it a secondary oocyte, finishing out meiosis 1, but getting froze at metaphase 2. And the follicle becomes a corpus luteum. He's going to start putting out progesterone to prepare for the fertilization of an egg. Now, if you are not pregnant, that guy's going to attrease and go into corpus albicans and then just become scar tissue. So that phase, when you have that ovulation to the end of this cycle, that's 14 days. If you are pregnant, the corpus luteum will continue to release progesterone for 3 months, and then the placenta is going to take over. Beautiful pictures. And then we're going to have negative feedback. So you're going to have these rising progesterone levels. It also does release some estrogen, but the key here, we're in luteal phase, luteinizing hormone, causing a corpus luteum, causing progesterone. Okay, I got progesterone, and so now we can inhibit luteinizing hormone and follicle stimulating hormone release. That's going to prevent follicle development for the next phase for now. But remember that corpus luteum is going to start to go away because he's going to figure out there is no baby. There's no baby. There's no need to put out progesterone anymore. No progesterone anymore. So what's going to end up happening? We're going to end up having a follicle stimulating hormone come again. This is one way that birth control pills can work. Let's keep that progesterone level high. And so I said all this, blah, blah, blah. So here is the menstrual cycle. Okay, so leaving the ovarian cycle, moving on to the menstrual cycle. Okay, so body has figured out you're not pregnant. Corpus luteum starts to become corpus albicans. Corpus albicans becomes scar tissue, and the body's like, okay, no baby. Day 1, menstruation. So the menses is going to last 5-ish days. Some people are less, some people are more. And then we're going to go to the pre-ovulatory phase. And this is where that the functional layer of the endometrium starts to build up. It's just starting. We're going to have some mild changes. And then, after ovulation, it's going to become greater because we think we could be pregnant. But then the luteum's going to figure out, nope, no baby. That's going to be the secretory phase. That's the one that's set in stone. Day 14 to day 28. So mid-cycle, ovulation, 14 days, we're done. Oh, forgot that I had all this all like this. Sorry. Okay, so at the menstrual phase, we're starting over. So hormone levels are going to be at their lowest during this point. Already said all this. But at the end of menstrual phase, then the follicle stimulating hormone is going to pick back up again. So that we can start all that cycle all over again, the follicular phase. So with the follicle stimulating hormone, remember we're stimulating follicles, and follicles can release estrogen. So we're increasing the estrogen, and the estrogen is what's telling the functional layer of the endometrium to get thicker. Here, as we get closer to day 13, 14, you'll notice that the cervical mucus, any discharge from the vagina, is now not mucoid. It's starting to get kind of watery. It's getting thinner because we're going to allow passage for the sperm. mucus, remember, blocks sperm passage. So at the end of a proliferative phase, the last day, 14 approximately, all women are different, but midway, we're going to ovulate. This part is the one that's steadfast and true, 14 days. That endometrium is preparing for the embryo to get implanted. So ovum has popped out, secondary oocyte, and is doing his traveling. Do. Maybe or maybe he doesn't need a sperm, but do. And here he comes into the uterus, and the body's got this area that's perfectly set. That endometrium, that functional layer, is just ready for taking care of that baby. We're going to have the corpus luteum is going to start to secrete progesterone also, which is going to stimulate even more the functional layer, and we're going to reform that thickened mucus to block entry of any more sperm or whatever. We've done our job. We've ovulated. If there's no sperm by here, too late, so sad. And then we have day 15 to 28. If fertilization does not occur, the body recognizes that, and the corpus luteum is going to say, I guess I don't need to release this progesterone after all. It starts to drop. So if it starts to drop, then that functional layer is, what am I here for? There's no purpose for this. So we're going to go and start back at day 1 at the beginning of the menstrual cycle. Cool pictures just to kind of show those little spikes. Cool pictures to help you out. More cool pictures to help you out. Notice that big spike in estrogen right there. Who's doing that? That giant spike of estrogen is coming from that Graafian follicle. Yay, I am the strong man. I have done it. Woohoo! And that's going to end up causing a surge also of luteinizing hormone. This is showing the thickening of the tissue. So what we're trying to show here is how we had at the very far left, uterus was ready for the baby. There is no baby, so that layer is going to get less and less and less with menstruation. And then we're going to start to build it back up again. Ovulation, you're at your peak. I'm ready. We're great. Thanks. Bring me the baby. What? There's no baby? Okay, we're going to start to taper down again. Okay, people that are extremely active, especially like swimmers and track runners, does that even make sense? I don't know. Lean women, they might be later to start their menstrual cycle. So instead of starting at whatever, 11 years, 12 years, 13 years, they might be 16, 17, 18 years. The term for cessation of menstruation, so people that are really thin, maybe crash diet, really sick, whatever, all of a sudden your cycle stops, or you just decide, you know what, I'm going to be an athlete. I never liked running before, but you know what, I bet I can do that. It looks kind of fun. You might completely stop menstruation. Okay, women sexual response is going to start with emotional needs. So to start with, guys, you got to be nice to her, because if you're not nice to her, if you're emotionally abusive, then or even not even abusive, neglectful, emotionally neglectful, women are, it's going to be harder to get her interested in you. Men are different. Men are visual stimulus. So their brains are definitely wired different. It is what it is. Men are from Mars, women are from Venus. It's different. But I read one time that women need 7 meaningful kisses a day. So not just a smack on a cheek, a genuine, wow, I really love you type kisses. That's a woman. Men don't need that. Just show me a picture of a naked person or just get naked and woohoo! So women are different from men. Let's see, the clitoris, we've already talked about that being a homologous structure to the penis, so it is stimulated by touch, and everything actually is that part, so engorgement of female parts, including the nipples, is similar to men. Vestibular gland, I've talked about that. That is, you've got one on the left and the right side of the vestibule, and it is just like the bulbourethral glands. Okay, orgasm is just rhythmic contraction. Of course, the job is to be trying to bring the sperm up to the fallopian tube / oviduct / uterine tube. It is not required to get pregnant. So, don't know how else to say that. Men have to have an orgasm to get the sperm out, but women do not have to have an orgasm. Now, here's a difference in females and men. Men have a long refractory period, so after orgasm, it takes a while for them to recover to be able to have a second one. Women actually don't have a refractory period, so they can have multiple orgasms. Sexually transmitted disease, also known as venereal disease. All of these can cause a problem with getting pregnant. So also, birth control pills don't prevent spread. The only thing that's going to help prevent spread is being careful with condoms or abstinence. Chlamydia, also known as the clap, I believe, is the most common bacteria. And pregnant women get tested for this because that actually can cause a problem in the newborns. They can get pneumonia from it. It actually can scar up their eyes because they'll get some of that chlamydia in their eye in the birth canal. Anyway, you might not know that you have it. So they test women. It's one of the tests that they get whenever they find out that they're pregnant, and then I believe again before birth. Gonorrhea, sometimes no symptoms, can pass it on. Oh, I forgot to mention, chlamydia often will have like a burning sensation with urination for both men and women. By the way, this is both men and women. Men might actually have pus dripping from their penis from this. What else? Sometimes it actually kind of blocks up the entire duct system. That's how it can cause a problem, both in men and women. Also treated with antibiotics. Now, this one has become resistant, so they're having to move on to stronger antibiotics. Syphilis. This one is terrible. This one can kill a person. Not nearly as common as it used to be. It was a problem more in the Middle Ages, but we actually have come a long way with that. So, this bacteria, treponema, there's different kinds of treponema, but this one can actually infect the fetus and cause the baby to die, be born before birth or immediately after birth. There's a period of time actually that you are asymptomatic, so you won't know for a few weeks, and then for a bit you're going to get like a sore that develops, a sore that doesn't hurt, and then it's going to go away. Other things that can happen, syphilis can attacks the whole body. Obviously, if it can kill you, you don't die because your penis falls off or anything. You die because it invades other tissues. So it can actually go into your brain and make you cuckoo. I'm trying to remember one of the Russian kings or czars. Oh, I think it was a long time ago. I think it was king. It was Catherine's husband. He went cuckoo, I think, from syphilis. Anyway, now we have penicillin. Treats that. Here's HPV. I'm so glad I wrote it out somewhere. Human papillomavirus. Totally forgot about this. So papilloma means wart. There's lots of different kinds of papillomaviruses. So if you've ever had a wart, this is not HPV. You got a wart on your finger, this is not HPV. That's a different papillomavirus. This one is just like we have lots of different kinds of RNA viruses, there's lots of different coronaviruses. Coronavirus has been around forever. But this one, this strain, is brand new. 80% of cervical cancers have come from HPV. But again, cervical cancer can happen because of other things too. So first, it causes genital warts, but so that is a dysplasia. That is, the tissue is forming something odd. Warts aren't cancerous. This would be a progression from that. This would be that odd tissue, that precancerous tissue becoming cancer. Herpes. 85% of people are asymptomatic and so hence have no idea that they have it. This is a biggie. So, multiple sex partners, anybody that has had multiple sex partners, you can find out even 10 years later down the road or more that you have contracted this. Just like chickenpox lends itself to the herpes that you get, the cold sores that you get on your lip. So when does that show up? With stress? This is a similar thing. Herpes can be a latent virus for an extended period of time, and then often with stress is what's going to make this guy flare up. And all of a sudden you're like, boom, what the heck is that? So this is not curable, but again, antiviral agents will help with this. And people that get, some people, there's different kinds of herpes. Obviously, cold sore is not this one. But if you get cold sores frequently, you might get put on an antiviral agent. Some people, instead of it, the chicken pox becoming just a cold sore problem, maybe they actually get, believe it or not, like migraines from this, or problems with their eyes, like long-term problems with their eyes. So they just stay on antiviral agents. Anyway, I'm going off too much into herpes because I'm supposed to be talking about genital herpes. It's just a really odd virus. And so genital herpes, which is different from the chickenpox herpes, you can get this easily because most people don't know that they have it. Okay, determination of sex. Okay, mom and dad, on their 23rd chromosome, they have either a mom has XX or men have XY. One from mom, one from dad. Okay. So X, obviously, for XY, X would come from mom and Y would have come from dad. So dad determines if the baby is going to be male or female. Sometimes when we have division not working out right, so you end up having multiple X's, like 3 X's or 2 X's and a Y, 4 X's, you're going to end up with usually some sort of disability. I left Klinefelter's in here because Klinefelter's, in my mind, is a perfect example about how when we'll say somebody has a mental illness, but we don't know why. Klinefelter's, we know why. They're mentally, like 95% of them are criminals. 95% of them, any range from theft to rape to murder. Here is a genuine link that we can prove that something caused that mental illness. Physically, something happened to those chromosomes. And I genuinely feel like a lot of, and it's hard to prove, but a lot of mental illness, we hopefully someday can be able to find out a cause. We can't fix somebody's chromosomes. That's their DNA. But other things that make somebody not right, whether it's mild abnormality or major abnormality, maybe we can find out some sort of medical cause and treat it. So Klinefelters, XXY. They're sterile, but their book says they're normal or only slightly below normal intellect. That's intellect, but behavior is different. Behavior, they might not be normal. Oh, no, it's not. Darn it. One more. Okay, this is showing development. So less than 2 months old is the top area. And pretty cool to see how these things come together and differentiate into a boy or a girl. So I've already mentioned these things about how the labia actually fuse for a male. And so that's the homologous structure. The labia homologous structure is the scrotum. The penis homologous structure is the clitoris. So anyway, that's it. Okay, finally. So we have these ovaries. The ovaries decided to become testicles instead. They have to get to the scrotum. There's actually a cord that's physically going to help pull it down. It's called the gubernaculum. The ovaries are going to migrate upward and be held in place by that broad ligament at the pelvic brim.